Yeah, thank you. Good morning, all the esteemed speakers and delegates. I, Dr. Manisha Praveen Shinde, Clinical Secretary, Akluj Obstetric and Gynec Society, welcome you all for a webinar on recurrent pregnancy loss insight. We all deal with recurrent pregnancy loss in our practice with tender love and care. And today, with the insight from our renowned speakers, will definitely help in our management. I request all to please post your questions in the chat box so we will have the discussion at the end. We'll start our webinar with the presidential speech of our most sincere president, Dr. Priya Gadam ma'am.
Good morning, all the respected faculties and online delegates. Akluj Obstetric Society is a budding society of only 30 members. It's our privilege to be associated with AMOGS. Dr. Kiran Koti sir was so cooperative and supported AOGS to plan this webinar on recurrent pregnancy loss. Also, Dr. Nilesh Balkavde sir, Dr. Chaitanya Ganfule sir, Dr. Mugdha Raut ma'am, and Dr. Ashish Kale sir gave the confirmation without any delays. We hope that this webinar would definitely throw light on the gray areas of use of heparin, immunoglobulin, uripristal, then hypothyroidism and fertility related issues and unexplained RPL cases. Thank you. Over to you, Manisha.
Thank you, ma'am. We'll start our first lecture. That is role of heparin in RPL by Dr. Nilesh Balkavde sir. I request Dr. Vinod Shetty sir to introduce Dr. Nilesh Balkavde sir.
Hello.
Yes, sir.
Hello. So
yes, sir, you're audible.
Good morning, everyone. Here I am give the introduction, brief introduction of Dr. Nilesh Balkavde sir. Regarding his today's lecture is on the role of heparin in recurrent pregnancy loss. Regarding his qualification, he has done MBBS, MS, DNB in OBGYN and MS. He is a fellow of Indian Association of Gynec Endoscopists, fellowship in reproductive medicine, diploma in Gynec endoscopy at Kiel, Germany. He is a clinical head and fertility specialist at Oasis Fertility Center, Pune. He is a chairperson of Quiz Committee, FOXY, in 2021 to 2025. He is a past clinical secretary of POGS in 2021-22. He is a member of Infertility Committee, AMOGS, 2020 to 2022. Regarding his awards, he got golden medalist at Dr. Vaishnapan Medical College, Solapur. He is a winner of FOXY, Dr. Usha Krishna Quiz in 2009 at West Zone at Nagpur. He is the best debutant at POGS, Dr. Smita Zog Award in 2014 and 15 by POGS. He has a pre-paper first prize at MSR. He got Dr. Shirish Daftari Award for original research by Pune OBGYN Society in 2020. Regarding his publications, he has got 2 national and 1 international publications. He is a books editor for 3 books. Souvenir edited 5. The chapter contributed 7. He is the editor of Foxy Focus 3. He is a faculty at various international, national, and UFOXY and state conferences. With this brief introduction, I request Dr. Nilesh Balkavde sir. Over to you, sir.
Thank you, Shetty sir. Thank you so much for that kind introduction. Without wasting much time, I'll start my topic for today, and it is enoxaparin, that is low molecular weight heparin in RPL. I won't talk much about RIF. So give me a moment, please. Yeah. So recurrent pregnancy loss traditionally has been, since this is my first, I'm in the first in the line for this RPL lecture today, I'll be going on to the brief introduction about RPL and various causes of RPL as well before I go into role of LMWH. So it's 3 or more consecutive miscarriage, what was initially called as RPL in 2006, but as we have come to this current scenario, even more than two recurrent pregnancy losses are supposed to be investigated, and therefore the definition can have certain change. Still, we are in a dilemma and we cannot reach to a perfect cause because 40 to 50 cases of our percent cases of RPL are unexplained. The rest can be anatomical factors, autoimmune factors, endocrine factors, infections, and genetics. Out of all these factors, the anatomical factors are, I feel, the most treatable part. That is the 30%, 20 to 30% of the cases of RPL can be considered as a treatable whenever you find the anatomical cause. And this can be a genetic anatomical cause, like there can be then there can be acquired intracavitary cause like submucous myoma, polyps, and intrauterine adhesions, acquired external cause such as fibroids, adenomyosis, and cervical incompetence. This can be diagnosed easily, and the preferred mode of diagnosis nowadays is a transvaginal ultrasound with 3D ultrasound, clubbed with or without a hysteroscopy. And acquired intracavitary causes can also be studied by the same methods. MRI and other advanced techniques are less likely to be required for the diagnosis of these anatomical causes. The gestational age for RPL is very, very important. When it is first and early second trimester miscarriages, you suspect anatomical cause such as septum or bicoordinate uterus. If it's early pregnancy loss, you suspect an adhesion. If it's a first trimester loss, you suspect a severe adenomyosis or fibroids. If it's a loss between 18 to 22 weeks, you suspect cervical incompetence. So as shown here, the 3D ultrasound has replaced MRI and even laparoscopy for diagnosis. MRI is not at all recommended as a first-line option for this, and treatment of RPL in these cases has a very good role, and we can come to a conclusion of and we can get very good results with this treatment. So here is about the treatment for different types of anatomical lesions. But when it comes to other causes of RPL, such as the unexplained causes and the thrombophilias, we need to find out that what can help, what we can have to treat these patients. So thrombophilias are inherited and acquired, and we know that it predisposes a woman to a risk of thromboembolism, and this risk usually predisposes to either recurrent implantation failure or recurrent pregnancy losses. It can be of two types, inherited and acquired thrombophilias. We know that inherited thrombophilias have a genetic predisposition, and factor V laden mutation is the commonest inherited thrombophilia. It is associated with uteroplacental thrombosis leading to fetal loss, preeclampsia, and late pregnancy complications as well. When it comes to antiphospholipid antibody syndrome, it's a condition where one or more thrombotic complications of pregnancy are seen, either in the venous, arterial, or microvascular circulation, and with a diagnosis of antiphospholipid antibodies. Now, these are a group of antibodies that bind to phospholipids, phospholipid binding proteins, and they include a protein called as cardiolipin, beta-2 glycoprotein 1, and a protein called as annexin 5. Usually seen in young women, and 10 to 15% cases of miscarriage are usually associated with antiphospholipid antibody syndrome. Now, this pathophysiology, if we see that of antiphospholipid syndrome, it can be because of two mechanisms. One is a thrombotic mechanism, and another one is a non-thrombotic mechanism. It has also an adverse effect on the trophoblastic function and differentiation, and therefore this can also be affected. The embryonic implantation and the placentation can also be affected. So if you see the thrombotic mechanism, the antiphospholipid antibody binds with the platelets and endothelial cells of blood vessels. It decreases the level of anticoagulants such as protein C and protein S, and activates platelet activation and aggregation. This forms a clot either in the forming trophoblast or in the placenta. Considering its non-thrombotic action, the antiphospholipid bind with the phospholipid beta-2 glycoprotein, and this hampers the trophoblast cell function and differentiation. And therefore, there is a defective invasion of this trophoblast, and therefore, these patients are at a predisposition of preeclampsia, sudden IUDs, and also IUGR. So this is a direct damage to the trophoblast, which is seen because of these antiphospholipid antibodies. And this also impacts the implantation, and therefore the success rates of IVF may also go down in such patients. Now, the goals of treatment in this category of patients is to improve maternal and fetal outcomes by decreasing complications such as maternal thrombosis, fetal loss, preeclampsia, fetal growth restriction, and increasing the rates of implantation, increasing success rates. The treatment options available for thrombophilia till date are low dose aspirin, unfractionated heparin, and low molecular heparin, that is the enoxaparin. Most of the times it's used. Successful implantation results from the action of trophoblast cells. A healthy embryo and a receptive endometrium both are required. Recurrent pregnancy loss, we have already defined it. Recurrent implantation failure is usually defined as transferring 3 good quality embryos and getting no good result in any of this. May it be 2 at a time or 1 at a time. So we see that antiphospholipid antibody not only contributes to RPL, but also the cases of RIF also. So it is one of the most important treatment for RIF and RPL would be low molecular weight heparin. Of course, it should be clubbed with low dose aspirin, that which can be around 75 milligram or 150 milligram, because it is seen that the combined action is more better than the single action of low molecular weight heparin. But here I am going to not talk about low dose aspirin much, going to talk about enoxaparin. ART failures are frequently positive for thrombophilia. Enoxaparin modulates many physiological processes like blastocyst apposition, adherence of the embryo, and the implantation. Ovarian stimulation with gonadotropins is associated with this risk in increased risk of thromboembolism, and of course the risk is reduced with the use of low molecular weight heparin. It has shown that it improves the live birth rate as well in RIF patients, and has been shown to be effective in RPL cases as well. Now, how does this low molecular weight heparin acts? It can act by either anti-thrombotic mechanism or another mechanism that is called as the non-thrombotic mechanism. And therefore, it is now being speculated whether we can use this treatment not only for antiphospholipid antibody syndrome, where it is evidence-based and validated treatment, but whether can be used in unexplained cases of RIF and RPL. So that's what we are going to see. So if we see that there is an intrinsic pathway and the extrinsic pathway for coagulation, and the factor 10A is where this mechanism, where is the important coagulant which is going to cause coagulation with the help of antithrombin 3. And low molecular weight heparin is going to cause deactivation of factor 10A and factor 2A in a 4:1 ratio, and therefore the clot formation will be prevented, and it's going to be a anticoagulant of choice nowadays in pregnancy. Now, do you know that the antithrombotic mechanism? Now, what is this non-thrombotic mechanism? So it binds to antiphospholipid antibodies and inactivates them, and this is very important. It interferes with the binding of antiphospholipid antibody to trophoblast cells, protects the trophoblast from injury, and restores the normal trophoblast invasiveness and differentiation. And probably by this mechanism, the implantation is going to improve, and by this mechanism, the placentation is going to improve, and therefore both of these is going to cause a good obstetric outcome with regards to the patient. Also, it is postulated that low molecular weight heparin restores the angiogenesis. It inhibits the complement activation, thereby reducing the inflammatory cells. Activation of tissue factor and endothelial damage, all these are prevented with the help of low molecular weight heparin. So we are now seeing the mechanism of action. Now we come to the use of low molecular weight heparin versus unfractionated heparin. So we know that the molecular weight of unfractionated heparin is quite high. The activity against factor 10A is great, but the side effect profile is more in cases of the unfractionated heparin, and it has to be monitored carefully, and it requires a strict monitoring. The bioavailability decreases is more in low molecular weight heparin. Half-life is again more. It is less bound to the plasma protein, and therefore easily reversible action of low molecular weight heparin can be considered. Regular monitoring is usually not necessary for low molecular weight heparin. There are less or rare cases of thrombocytopenia because of it, but as in unfractionated heparin, it's definitely going to predispose the patient to thrombocytopenia and other complications, and therefore strict monitoring of the factor 10A levels and the CBC is necessary whenever the patient is on unfractionated heparin. Now, what is the dose of treatment? Whenever we are using it for prophylaxis without the patient doesn't have any history of thromboembolism, and you are using it as a prophylaxis, the dose is around 40 milligrams subcutaneously every day. But when his patient has history of any thromboembolic episode in the past, also there is a history of bad obstetric history, sudden IUD. These patients are those whom we have to give a BD dose, that is every 12 hours, in a dose of around 1 milligram per kg to 1.5 milligram per kg per day. So these regimens are now considered as safe even in pregnancy. So the treatment of antiphospholipid antibody in pregnancy, patients with antiphospholipid syndrome without previous thrombosis, but had recurrent early pregnancy losses or fetal death, the prophylactic doses of low molecular weight heparin and low dose aspirin should be given and should be continued 6 weeks till postpartum. This is not a rocket science. This is given in our books, that is Williams Obstetrics. Patients with antiphospholipid without previous history of thrombosis but had early previous delivery. In this patients, low dose aspirin and prophylactic low molecular weight heparin should be continued at least till the 8th month. Patients with antiphospholipid antibody syndrome with history of thrombosis. In these patients, we have to give a therapeutic dose of low dose aspirin and low molecular weight heparin, and usually started after documentation of the first heart activity, that is around 6 weeks, and stopped 24 hours before induction or before the patient goes into labor, because the action, the reversal, as we have seen, is going to be very, very fast, as the plasma binding is low in cases of low molecular weight heparin. Now, what are the contraindications? So if there is any history of active major bleeding either in the first, second, or the third trimesters, we don't give. Thrombocytopenia, which is because of heparin, less likely because of low molecular weight heparin. But if it is there, then we need to be careful and stop low molecular weight heparin and see whether it's responding, and maybe use another drug molecule for this low molecular weight heparin. Hypersensitivity to this LMWH can also be a contraindication. Patients who are at increased risk of hemorrhage with bleeding diathesis from a previous history of thrombocytopenia, history of mechanical prosthetic valves, require a regular frequent monitoring in these patients. Usually well-tolerated drug. The most common adverse effects could be bleeding, anemia, thrombocytopenia, elevation of serum aminotransferases sometimes, and sometimes diarrhea and nausea as well. Low molecular weight heparin doesn't cross placenta, and therefore it is safe to use during pregnancy. It is well tolerated, not associated with the increased incidence of PPH, and the incidence of thrombocytopenia and osteoporosis are also less. It's given by subcutaneous route, and therefore a patient can self-administer the drug by either a pen or a single-use syringe. Now, what are the clinical evidences for use of enoxaparin in RIF in IRT? So this is very helpful, not only in RPL cases, but it can be also used in RIF cases. So we have randomized a prospective study of the 60 women, which was undertaken in RIF cases, and it was shown that the low dose aspirin along with low molecular weight heparin was more useful than the unfractionated heparin. Low molecular weight heparin versus unfractionated heparin in recurrent pregnancy losses with antiphospholipid antibody syndrome. Again, this was a prospective study which included 25 patients in each arm. There was not significant difference in the effectivity, but the side effect profile was very much improved with the use of low molecular weight heparin as against unfractionated heparin. Adjunct low molecular weight heparin to improve live birth rate after recurrent pregnancy, recurrent implantation failures in IVF patients in 2030. This systematic review and meta-analysis was undertaken, and RIF was defined as more than 3 IVF failures or with good quality embryos, and it was seen that the overall live birth rates were 75% in the combination group of aspirin as against aspirin alone, and therefore it significantly improved live birth rate as against only aspirin treatment. So therefore low molecular weight heparin can be considered as a management. Now, what does all the institutions say? So in cases of antiphospholipid antibody syndrome, whenever it is a diagnosed case, either inherited or acquired with or without any history of thrombophilia, RCOG, ACOG, American Association of Chest Physicians, British Journal of Hematology, all recommend the use of low molecular weight heparin for this indication. So because of the safety, efficacy, and use of low molecular weight heparin, it has greatly replaced the unfractionated heparin in the obstetric practice, and therefore it can be used in antiphospholipid antibody syndrome. patients with recurrent implantation failure, this is a little bit gray zone, because if we see a large studies, it has not been given as a recommendation for use in RIF patients. But as we have seen the use of low molecular weight heparin, not only in cases of and not only is anti-thrombotic mechanism, but also other non-thrombotic mechanisms of immunomodulations and favoring the trophoblast, these are going to help the patients of RIF in ART, and therefore this remains an indication for use. So it prevents the thrombosis and prevents subsequent placental infarcts as well. It improves the trophoblast invasion and function, and combination therapy is greatly useful. We have already seen that in comparison to unfractionated heparin, it has a higher bioavailability. Elimination half-life is just 4.5 hours. It does not require a frequent monitoring. The side effects of thrombocytopenia, osteoporosis are quite less whenever it is used as against the unfractionated heparin. So it's a safe and effective treatment. And for those cases of unexplained RIF, we can definitely try low molecular weight heparin in those patients also. And in cases of antiphospholipid syndrome diagnosed previously, this is already a recommendation by all the international authorities. So thank you for your patient hearing. Thank you.
Thank you, Dr. Nilesh. That was really a fantastic talk.
Thank you, sir.
Thank you.
Now we'll
Thank
move
you,
over
sir.
to our next lecture. For this, I call on Dr. Madan Kamai, sir, to introduce Dr. Kiran Kurtukoti, sir. His lecture is on a role of immunoglobulins in RPL.
Slide, please.
Yes, sir.
Yeah, it's my privilege to introduce respected Dr. Kiran Kurtukoti, sir, who is currently Vice President of AOGS. We have recent memories of his visit at Akluj in December 21, and thank you, sir, for that. Yeah, I would like to introduce, sir. He is ex-chairperson of MTP committee of FOXI in 2009, and he is ex-chairperson of MTP committee AMOGS, also medical education, research and training committees of AMOGS. He was ex-joint secretary of AMOGS in 2009. And he is the managing council member of Pune OBGYN Society. He has organized many conferences, national and international conferences, and he was organizing chairman, secretary, convener of national and international conferences. He was ex-vice president of AOGS. He is the director of Shashwat Multi-Speciality Hospitals India Private Limited and Shashwat Hospital owned.
Dr. Madan, thank you so much. I think let's get on with the presentation. Thank you so much. Please allow me to share my screen. Please allow me to share my screen. Yeah.
Yes, sir.
Yeah. At the outset, a warm welcome on behalf of AMOGS to everyone, to the entire family and fraternity of Akluj, as well as those who are watching this particular program live. And Dr. Kadam mentioned that Akluj Society is a small society, but no, Akluj is right now on the map of AMOGS, mainly because of the various conferences and programs that you are organizing. And I'm sure that the founder of Akluj Society, Dr. Vandana Gandhi, must be feeling really proud of all of you, because you are doing so much work in AMOGS. And thank you, Madan, for the kind introduction. Madan has been working from AMOGS, I guess, for the last 1 year or so, and has arranged many nice conferences, especially on the sexual medicine conferences. And I'm sure that he will continue to do so in the years to come. So thank you so much. Thank you, Intas, also.
Sir.
Thank you, Intas Pharmaceutical, also Svikar, Tahir, and everyone in Intas for accepting our request to support this particular program. And I'm sure that in the next 6 months to 1 year, we will have about 12 such programs, physical ones, all over Maharashtra. So thank you, Intas, for their support and guidance. Now, I'll be talking on the role of immunoglobulin in the management of RPL. And yeah, So this will be the flow of events. I think, is it visible full screen? Yeah. So this will be the flow of events. Now we all know that pregnancy acts as a semigraph. Why is pregnancy a semigraph? Because the child carries two genes, one from the mother and one from the paternal gene. So the paternal gene, of course, is foreign to the mother. So mother gene are also going to initiate the antigen antibody response, but all babies do not abort. So let us see why they do not abort, or what is the kind of immunomodulation that occurs in pregnancy. We all know something about basics. Let us go back to the second MBBS and let us learn something about the T lymphocytes. Now these T lymphocytes are classified into the cytotoxic or killer cells, cytotoxic T cells, and T helper cells. So I have purposefully shown them as red and green and blue. So what these T helper cells are going to do, the Th1 cells, they produce inflammatory. They are angry cells, you can say. So these are pro-inflammatory cells. And Th17, these are also pro-inflammatory cells, and these are mainly responsible for the graft rejection. So T17 cells take important role in graft rejection, especially when you are doing organ donation programs. Okay. Now Th2 cells, these are anti-inflammatory, or they calm down. They have a calming down effect. Therefore, they have coded them as blue. So they are anti-inflammatory cytokines, and the other one are T regulatory cells. These are also anti-inflammatory cytokines. So these are the various types of T lymphocytes which play an important role in the antigen and antibody reaction. Now these Th17 cells are also closely related to the T regulatory cells. As we previously saw that the T regulatory cells are anti-inflammatory, anti-inflammatory. So the what it has been found out that defect in the number or function of the T regulatory cells are documented in the spontaneous abortion or unexplained recurrent spontaneous abortions. Okay. Now, what happens during pregnancy is there is increase in the tolerance of T regulatory cell activity and decrease in the pro-inflammatory or T17 cell activity. Now, because of this particular mechanism, there is acceptance of the fetus, which is actually a semi-antigen. So failure of this adaptation is going to cause rejection of the fetus and is going to cause loss of pregnancy. So this simple immunomodulation is such an important thing that has occurred since ages together. Okay. Now, what happens in pregnancy is there is a shift. What is the shift? It is towards a protective or Th2 dominated cytokine balance, and it is away from the Th1 cytokines like interleukin 2, alpha and interleukin 12. Okay. In addition to this, we all know that pregnancy is a progesterone is a condition wherein the progesterone activities are at the peak. So what does it do? Progesterone induced blocking factor, it prevents inflammatory and thrombotic reactions towards the fetus, and therefore promotes this shift towards the Th2 cytokines. So this is the immunomodulation which occurs during pregnancy. Okay. So this Th2 cytokine response antibodies are going to mask the fetal trophoblast antigen and going to prevent these antigens from immunological reaction by the mother's T1 cell mediated cytotoxic response. So indirectly they cover these antigen or the fetal antigen. So in women with recurrent miscarriage, they tend to produce mainly the Th1 type response in both the period of embryonic implantation and also during the pregnancy. So at the time of implantation window also, and after the implantation also, the women with recurrent miscarriages are going to produce mainly the Th1 type antibodies. Okay. So this is the rough balance, that is Th1, Th2. In pregnancy, what happens is Th1 goes down, Th2 improves, and Th2 is mainly responsible for continuation of the pregnancy. Another cells are the natural killer cells or the NK cells. Now, what these NK cells do, they with the help of Th1, they cause the programmed death of the trophoblast and inhibit the growth of the trophoblast. So patients who abort have increased N cell activity. Okay. Now it comes to our mind that why don't we measure the NK cell activity by flow cytometry in all cases of recurrent abortions? But if you go to the guidelines of HTA in 2017, they do not promote it is not advisable to do the NK cell activity in each and every case of recurrent abortions. Okay. So let us discuss what is RPL. As Nilesh previously described, RCOG defines RPL as 3 consecutive pregnancy losses. But we know nobody in at least in our practice setup, nobody is going to wait till 3 pregnancy losses occur before we start investigating. As a matter of fact, even if there is 1 pregnancy loss, then people are going to start investigating. And as Nilesh rightly said, that this definition is likely to change in the years to come, because ASRM says it as 2 or more clinical pregnancy losses. But we find in our practice that even if there is 1 pregnancy loss, then people are anxious and ask us to investigate more. So this definition definitely is going to change. Now let us see what is RPL. Primary, we all know it is a series of pregnancy losses without a previous live birth. And in secondary RPL, it defines series of pregnancy losses subsequent to a previous live birth or a stillbirth. Again, there is a small entity called as RIF. People who are doing IVF, they will be well aware with what is recurrent implantation failure. So failure of implantation for at least 3 consecutive IVF attempts, in which 1 or 2 embryos of high grade quality, that is more than A plus activity, are transferred in each cycle. So we are not talking about B or C grade embryos, but about A grade embryos which are being transferred. Now these are the various causes of RPL, and this is a more comprehensive data or more comprehensive side. We all know chromosomal abnormalities, anatomical abnormalities, thrombophilias, but what we are going to talk is about the immunological factors, and we have discussed about cytokines, NK cells, anti-nuclear antibodies, HLA, and other immunological abnormalities like anti-HLA, celiac disease, and anti-sperm antibodies. So this has gained more importance, or today's lecture will be focused mainly on these immunological factors. We also have the endocrine and metabolic factors, which Chaitanya and Chaitanya will be taking later, and the genetic and the male factors. Okay. So let us understand what goes. Now, as the of implantation, as the embryo reaches the uterine cavity, the first determination of the implantation site occurs, and this is followed by the adhesion of the embryo to the endometrium. We all know that small pinopoids are formed, and which are responsible. There is a lot of immunological activity which goes on at the interface between the endometrium and the embryo, and which is responsible for the adhesion of the embryo or the attachment of the embryo to the endometrium, and the invasion of the endometrium and the establishment of the vascular connections of the maternal circulation occurs. Okay. Now, we have already said that increase in the Th1 activities are responsible in recurrent pregnancy losses. So immunological factors behind RPL can be classified into autoimmune, which are directed to the cell, which will have 2 associated autoimmune disorders like SLE and antiphospholipid antibodism, and alloimmune, which is an abnormal maternal immune response to the fetal or the placental antigen. So we are going to discuss only on the alloimmune rather than the autoimmune one. So in unexplained infertility, if you see, it is defined as those cases which does not have any identifiable genetic, uterine, endocrinological, or infectious or autoimmune factors. And a large number of these cases of RPL do not have a defined etiology. So they are unexplained, or we can classify them into unexplained RPL. And in all these 50% of cases, there may be a contributory role of immunological causes like increased Th1, Th2 ratio, increased Th17 T regulatory ratio, presence of cytotoxic antibodies, absence of maternal blocking antibodies, increase in the natural killer cell activity. So all these will be clubbed together in this unexplained infertility. Now, something about APS, Nilesh has already discussed about APS, so I won't go more into APS. So primary APS, in which patients do not have clinical or laboratory evidence of any other associated systemic disease, are identified as having primary APS, and the secondary APS. Okay, so the Sapporo criteria have been now modified, and these are the Sydney criteria, wherein you have laboratory criteria plus thrombosis or pregnancy related morbidity. So this has undergone change quite as recently as I think 2020. So these are the criteria for diagnosis of APS. Now this is the pathology in the APS. thrombotic and non-thrombotic. We'll not go into the detail. We'll now go directly to the immunomodulatory treatment. So this is the various treatment options available in RPL. Preconception tablet aspirin, either 75 or 150, whatever you feel appropriate. Tablet prednisolone, lymphocyte immunotherapy. I'm sure Dr. Raut will be, Dr. Mugdha Raut will be mentioning on that. Then immunoglobulins, low molecular weight, we have already seen progesterone or dydrogesterone, and HCQS will not be good delving on that. But everything, all the immunomodulation is evolves around changing the ratio between Th1, Th2, T regulatory and Th17 cells. Everything, even if you go to dydrogesterone, even if you go to RPL, everything evolves around the changing of this particular ratio. Okay. So let us see about the history of immunoglobulins. If you see, the intramuscular immunoglobulin therapy is available since 1960s, and IVIG became common in 1980. Thereafter, in 2006, it came the subcutaneous immunoglobulins were there, and now we are more into the intramuscular immunoglobulins. Okay, so we all know normal immunoglobulin contains mainly IgG immunoglobulin. When we talk about immunoglobulin, we are going to talk about IgG and not about IgM at all. So it is prepared from the pooled plasma of not less than 1,000 donations, and standard measures to prevent infections are taken whenever this particular immunoglobulin is manufactured. Okay, so as I said earlier, the underlying mechanism in RPL is correcting this Th1 Th2 ratio, expanding T regulatory cells, inducing a decrease in the Th17 and T regulatory ratio, and of course suppressing the NK cell activity. And these are the other mechanisms, that is reduction in the autoantibodies, controlling secretion of the cytokines, suppressing the superantigen, and apoptotic mechanisms and formation of immune complex. So all this is possible by the immunoglobulins. Okay, so they may cause neutralization of autoantibodies, decrease in the autoantibody production, decrease in the activity of autoantibody producing B cells. So this is the various action. Now let us go to the various evidences. So this is the evidence presented by Hutton in 2007 in women with secondary RPL. They have benefit from IVIG. Then Wang et al. Did a study in 2016 where the live birth rate was significantly improved in women with RPL if the treatment was started before conception, but not if it was started after conception. Okay. Now this was the paper presented in the Journal of Reproductive Immunology in 2019. Okay, this is prior IVIG. So 12 out of 15 patients, that is 80% success rate, and prior placebo only one. So that proves the importance of IV immunoglobulin before pregnancy occurs. Okay. Now this was again a meta-analysis. The live birth, the RR rate for live birth patients who received IVIG before conception versus those who received placebo was 1.69. That is, it was significantly variable, significantly improved. Okay, so this is the low dose and versus high dose study again, which is published in the Journal of Reproductive Immunology. 0.4 grams per kg body weight with 2 to 3 intervals. Again, this is the as latest as 2022. This paper was presented of the intravenous immunoglobulins to improve live birth rate among women with underlying immune condition. A systematic review was done, and this was presented in the Allergy, Asthma and Clinical Immunology Journal in 2022. So it is a very recent paper, and they have again stressed the importance of IV immunoglobulins. Now, the limitations of IV immunoglobulins are it is expensive, time consuming, and can cause few reactions. Okay. But so we come to the intramuscular immunoglobulins. So the advantages of IM immunoglobulins are maximum plasma levels are attained within 48 hours. It has got a long biological life. In fact, if you see the biological life of IV immunoglobulin, the half-life is about 21 days. So longer biological half-life. No risk of anaphylaxis and infections, and it immediately is going to produce give passive immunity. Okay, so what is the dosage? So the dosage is 2 ml subcute. You can start as early as soon as the pregnancy is diagnosed. you have to give it every 21 days. Why every 21 days? Because the half-life is 21 days. So you have to give it every 21 days till 36 weeks of pregnancy. Okay. So this paper was presented, I think, way back in 2006 when I was with Dr. Pankaj Desai in that conference, and this paper had received a lot of accolades for the presentation because he had done extensive work in RPL on immunoglobulins. So the recommendations given by him were this. Okay, so these are the contraindications: hypersensitivity reactions. It should not be given IV. The other advantages, as I rightly pointed out earlier, it is well tolerated. There is hardly any reaction to the injection site, and rarely it is. I mean, we have never seen any anaphylactic reactions because of this. So this is the clinical evidence, various clinical evidences. Okay, this paper was presented in 2017. A study on alteration of Th17 and the regulatory T cells in patients with unexplained RPL before and after the therapy. Okay, so the therapy protocol followed was a 0.3 gram Ig intramuscularly every 3 weeks till 14 weeks of gestation, along with supplementation of 2000 hcg intramuscularly every 2 days. Okay, so they have given this study, and this study is clearly showed the levels of Th17 and related cytokines, that is interleukin 17 and interleukin 6, decreased after the treatment. So they have decreased. Okay, and the levels of T regulatory cells have increased. Okay, so this particular study. Yeah, this particular study shows the before and after treatment of the Th17 and the T regulatory ratio. If you see, the ratio was more 1.5 to 2, and now it is less than about 0.5. So, so what they concluded, that the therapy of HCG, if you add HCG to immunoglobulin, it will reduce the Th17 and T regulatory ratio, which may be beneficial again for the maintenance of pregnancy. So this is again a big paper, a large study. This is another study again by Dr. Pankaj Desai, which I told earlier. Group B patients and Group A patients. Group A received HCG 5000 immunoglobulins every 21 days, along with this low dose aspirin, that is 75. So if at all you see, Group A and B received immunoglobulins every day, every 21 days till 36 weeks of pregnancy. Okay. So again, this is another study in November 2017, high risk pregnancy in patients with APS, SLE and bad obstetric history. So again, the treatment was initiated and immunoglobulin were given, and she did not develop any thrombotic episodes or any complications of preeclampsia. Again, this is a paper in which which has been presented in the Reproductive Immunoglobulin journal in 2016. So what they say, that subcutaneous immunoglobulin therapy was well tolerated and as efficacious in a selected case of unexplained abortions with multiple sclerosis. So a lot of studies have undergone in this, and to summarize, it is efficacious in the management of unexplained RTL, with the underlying mechanism that it may neutralize the autoantibodies, it may correct the abnormal Th1 Th2 ratio, induce a decrease in the Th17 and Treg ratio, and it is also efficacious as adjunct in the management of RPL due to autoimmune causes such as antiphospholipid antibody syndrome. So I guess I conclude with this. In the previous talk, I think Dr. Nilesh mentioned about low dose heparin. One must remember that when we are going to give low dose heparin, the INR ratio, that is the international normalized ratio, we have to maintain it between 2 and 3. It should not go beyond 3. There is no point in letting that ratio beyond 3. So just a small point which was to be added from the previous lecture. So I guess this concludes my talk. Thank you. Any questions, I'll be happy to address that. Thank you.
Thank you, sir.
Thank you, sir. Our next interesting topic is on hypothyroidism and fertility by Dr. Chaitanya Ganfule, sir. I call Dr. Mansi Revrickar to introduce Dr. Chaitanya Ganfule, sir.
Hello.
Yes.
Yes, Mansi,
Good
you're
morning,
on.
everyone. Welcome, Dr. Chaitanya Ganpule, sir. Good morning.
Good morning.
So today we are going to know about hypothyroidism and infertility. As we know, thyroid hormones have intense effects on fertility and reproduction, and prevalence of hypothyroidism is up to 2 to 5% in reproductive age group women. I think in rural areas nowadays we are seeing more and more cases of infertility related to thyroid. And like before, now we are investigating thyroid in more detailed aspects with antibodies and all. And it affects fertility in various ways, like unregulated cycles, menstrual dysfunction, luteal phase defects, and hyperprolactinemia. It affects FSH and sex hormone imbalance too. So, young women in subfertility and thyroid dysfunction is coming in a very big way. And I think nowadays autoimmune thyroiditis is the most common cause of hypothyroidism nowadays. So to enlighten us upon this difficult topic, I welcome Dr. Chaitanya Ganpule, sir. He is a director of Pearl Women Hospital and Yash IVF Pune. He is director of Noble Yash IVF, director of Satara Yash IVF, and he is a recipient of Times Health Icon 2020. He is is invited faculty, and he has got many publications in national and international journals. He has written a chapter in Jeffcott Textbook of Gynec and Foxy Focus and many other esteemed books. I welcome Dr. Chaitanya Ganpule, sir, and request him to give us some detailed information about hypothyroidism and how it affects fertility. Thank you, sir.
Thank you, Dr. Mansi, for that kind introduction. Can I start sharing my screen, please?
Yes, sir.
Can you see the screen?
Yes, it's visual.
Okay. Good morning, everyone. And at the outset, I would like to thank Akluj OBGYN Society and the President, Dr. Priya Kadam, Madam, and Dr. Kiran Kurti, first Vice President of AMOGS, for giving me this opportunity to be here today and discuss about hypothyroidism and infertility. As Dr. Mansi rightly said, that hypothyroidism is one of the major factors or important factors that can lead not only to infertility, but general menstrual disorders, disturbed folliculogenesis, and also the outcomes of ART, placentations, and recurrent miscarriages. Though the today's meeting or CME is mainly upon recurrent pregnancy loss, I am going to restrict myself to the fertility part of it and not moving into the recurrent pregnancy loss. The flow of my presentation is going to be, I will briefly introduce the topic, and then we will move on to see about what is physiology of thyroid function. Now, it's important for us to understand the physiology if we want to understand the pathology in the right way. Then we will go ahead and see what are the different types of thyroid disorders. What is the role of thyroid hormone in reproduction? Again, till the time we know what is the role of thyroid hormone in reproduction, it will be difficult for us to understand the pathophysiologic mechanisms of the thyroid hormone and infertility. Then we will discuss in short something about thyroid autoimmunity and its correlation with fertility, thyroid disorders and ART outcomes, thyroid disorders and the male factor. It's not that the thyroid disorders affect only the female partner, but it can also affect the male partner and the overall outcome of the fertility treatment. And then we will quickly summarize what we have learned so far. So as you all know, that thyroid hormone affects all the cells and organs of the body. Now it primarily controls the rate of metabolism of our body. Now, thyroid disorders affect about 1 to 3% of the general population. But when it comes to infertile population, this percentage is a little more, and about 2 to 4% of women are found to be hypothyroid when it comes to infertile population. Supplementation of levothyroxine has found to improve fertility outcomes in women with both hypothyroidism, which is overt, as well as subclinical hypothyroidism. So thyroid is a hormone which is synthesized by the thyroid gland, which is present in front of our neck. The function of the thyroid gland is controlled by the hypothalamo-pituitary thyroid axis, so which is called as HPT axis. and there is something called as an HPO axis. They are closely related, they function very closely with each other, and therefore whenever there is a disturbance in the hypothalamo-pituitary thyroid axis, there is a parallel disturbance which is seen in the hypothalamo-pituitary ovarian axis as well. Now there are two types of thyroid hormones which are secreted by the thyroid gland: T4 or thyroxine, and T3, which is also called as triiodothyronine. Now T4 is the predominant one, and it is the inactive precursor or pro-hormone which is converted into T3. Now most of the hormone which is circulated in the body is in the form of T4, and only small amount of biologically active T3 hormone is seen circulating in the body. Now, less than 0.1% of the circulating hormone is free and biologically active. So most of the activity of the thyroid hormone is seen once it enters into the target cell. Well, it was thought that the thyroid hormone passively enters into the cell, but recently it is found that it's not a passive mechanism, but there needs a presence of thyroid hormone transporters which are present on the cell membrane, which help to transport the thyroid hormone from the circulation into the cell. Now, once intracellularly, the T4, which is in inactive form, gets converted into T3 or the active form by the action of iodothyronine deiodinases. Now, there are three types of deiodinases which are present: D1, D2, and D3, out of which D1 and D2 are the ones which convert T4 from inactive form to T3, which is an active form. Now, once this active form of T3 is synthesized in the cell, then comes the role of thyroid hormone receptors, which are present within the nucleus of the cell, and then the actual action of the thyroid hormone occurs in or within the nucleus of the cell. Once we have understood the physiology of this, we want to understand what are the different thyroid disorders. Now, the grossly I can divide or classify thyroid disorders into hypothyroidism, wherein the circulating levels of free T3 and free T4 are less than what are expected; hyperthyroidism, wherein T3, T4 levels are more; and thyroid autoimmunity, it has been classified as a separate entity, although it ultimately leads to hypothyroidism, but it has been classified as a separate entity, and we'll discuss about it as a separate entity. Now, when it comes to hypothyroidism, it could be an overt hypothyroidism, or it could be a subclinical hypothyroidism, wherein we don't see the classical features of hypothyroidism. But when we do the blood investigations, we see that the TSH levels are high, and that's why it is classified as subclinical hypothyroidism. Is it important for me to differentiate between the two? Yes, it is, because overt hypothyroidism has got its obvious actions, but does subclinical hypothyroidism also has a role to play when it comes to fertility, recurrent miscarriages? Then that's a different subject altogether, which we are going to look at it separately. Now, when it comes to hypothyroidism or thyroid disorders and fertility, we must understand whether there is any role of thyroid hormone per se in the reproduction. If you see here, thyroid hormone receptors, deiodinases, and transporters, all of them are present in the oocyte. They are present in the endometrium. They are present in the placenta, present in the embryo, present in the baby, as well as they are present in the sperms. Now, when I say that they are present at all these organs or these things, that means they definitely have a role to play. So what are these roles the thyroid hormone has to play when it comes to reproductive system? So let's understand about thyroid hormone and folliculogenesis and ovulation. Now, thyroid hormone mRNA is found in the follicular fluid. Deiodinases are also found in the follicular fluid. Both T3 as well as T4 hormones are also present in the human follicular fluid. In vitro studies have shown that T3 stimulates the growth of preantral follicles. So T3 has a role to play in the growth of the preantral follicles, from the preantral to antral to preovulatory and ovulatory follicle. Another role which T3 has to play along with FSH, if not alone, is to stimulate and the proliferation of the granulosa cells. So it increases the number of granulosa cells. this does by stimulating its proliferation as well as by inhibiting the granulosa cell apoptosis by P13-AKT pathway. Now, it is considered that T3 is a biological amplifier of the action of gonadotropins on the granulosa cells. So when it comes to folliculogenesis, T3 is involved in the stimulation of preantral follicles for further growth, number one. It brings about the proliferation of the granulosa cells, number two. It inhibits the apoptosis of granulosa cells, number three. It amplifies the actions of FSH and LH on the granulosa and the theca cells. Now, when we know this, that means whatever thyroid hormone disturbances can lead to impaired folliculogenesis, impaired ovulation, and menstrual irregularities along with infertility. Thyroid hormone and endometrium. Again, thyroid hormone receptors, deiodinases, and transporters, all of them are found to be present in the endometrium, and they undergo a cyclical change. So thyroid hormone probably also has a role to play in the dynamic changes which take place in the endometrium throughout the menstrual cycle. So it's not only the follicle, but also the endometrium in which thyroid hormone plays a role. Now, does thyroid hormone has a role to play in fertilization and embryogenesis? Again, all these are seen or expressed even in a pre-implantation embryo. Now, why they should be there in a pre-implantation embryo? Obviously, they have to have a role to play when they are present in this pre-implantation embryos. Now, in humans, it is found that good quality embryos are significantly higher in women with subclinical hypothyroidism, which are treated with levothyroxine. That means thyroxine has a role to play as far as the quality of the embryos is concerned. So the supplementation of levothyroxine improves our quality of embryos, obviously will improve the chances of implantation and the chances of success. When it comes to implantation, T4 stimulates the production of progesterone by the granulosa cells. Progesterone, we all know, has a vital role to play to bring about the secretory changes in the endometrium, which allows implantation. Now, it is found that TSH significantly upregulates the leukemia inhibitory factor, LIF, which plays or which may play a role in implantation. So there is a role of thyroid hormone also as far as implantation is concerned. So you know, folliculogenesis, endometrium, fertilization, embryo quality, implantation, and lastly, placentation. Again, all these THR, THTs, and deiodinases are expressed in the placental tissues. Cell adhesion molecules, matrix metalloproteinases, these are all important in the cell invasion process and placentation process. What does T3 do? It increases the cell adhesion molecules and the MMP, and thus plays a role in better invasion of the placenta and later placentation. We know that majority of our obstetric problems or issues like PIH, IUGR, leading to preterm births and allo birth weight babies are because of faulty placentation. And therefore, if we can correct this placentation in women who are hypothyroid or who have got thyroid autoantibodies, which I will come to that later on, by supplementing levothyroxine, we are going to reduce our possibilities of IUGR, PIH, preterm births, and low birth weight babies as well. So friends, to underline, normal thyroid function is important to maintain the normal reproduction. Now, once we have understood what thyroid hormone has a role, thyroid hormone has to play in a normal reproduction, now it would be easy for us to understand what it has an effect to play when it comes to hypothyroidism and infertility. Well, there are various mechanisms by which hypothyroidism can lead to infertility, but as I said in the past, it is because of the interplay between the hypothalamo-pituitary thyroid and the hypothalamo-pituitary ovarian axis. What does it do? Hypothyroidism results in numerous hormonal changes. Now, the rate of metabolic clearance of androstenedione and estrone is decreased. At the same time, there is increase in the peripheral aromatization. So the clearance is decreased, peripheral aromatization is increased. That leads to increased in the unbound portion of the estrogen. it also decreases the sex hormone binding globulin. Now, if there is decrease in SHBG, obviously the unbound fraction of testosterone and estrogen are increased. Hypothyroidism also leads to a blunted LH response. Now, because the LH response is blunted, there is a negative feedback which is given to the hypothalamus, and it increases the TRH secretion. Now, TRH not only acts on the thyrotops of the pituitary to increase the secretion of TSH, but it also acts on the secretion of prolactin and increases the secretion of prolactin. When there is increase in secretion of prolactin, there is decreased pulsatile secretion of GnRH. This all ultimately leads to ovulatory disturbances. Now, hypothyroidism also is found to be associated with corpus luteal insufficiency. Along with that, there is a decreased production of progesterone and luteal phase insufficiency, leading to luteal phase defects and decreased implantation and decreased pregnancy rates. So this is how hypothyroidism is associated with infertility. So friends, if you see the hormonal changes which are seen in thyroid are marked by decreased levels of SHBG, increased levels of free estrogen, increased levels of free testosterone, and blunted LH response. This all leads to menstrual disturbances, and up to 80% of women with hypothyroidism can have menstrual disturbances, out of which menstrual irregularities are found in about 50 to 60% of women. Is there a link between fertilization and thyroid function? Now, this was a study which was published in 2003 by Kramer, and it found that TSH levels were significantly higher among the women who produced oocytes that failed to be fertilized. And this finding persisted even after adjusting for several covariants and including the sperm motility. So all those who failed to fertilize had higher TSH levels. So it concluded that TSH may predict poor fertilization in IVF and reflect the importance of thyroid hormone in oocyte physiology. Now, if this is the case, in IVF outcomes, the same would be probably true even for natural conception and even for after IUI cycles. Therefore, the 2017 American Thyroid Association guidelines say that evaluation of serum TSH concentration is recommended for all women who are seeking care for infertility. Let's discuss something about thyroid autoimmunity and infertility. Now, before moving on to autoimmunity, let's understand what are these thyroid peroxidases. These are enzymes which are essential for the synthesis of thyroxine hormone in vivo. They are expressed abundantly in the thyroid gland. What do? They oxidize the iodide to active iodine, which then binds to thyroxine to form a thyroid hormone. So the action of thyroid peroxidase is needed for a normal thyroid synthesis and thyroid gland functioning. There are two types of autoimmunities, or there are two types of autoantibodies which are found when it comes to thyroid. One is TPO antibody and the other one is thyroglobulin antibodies. However, most of the thyroid disorders associated with infertility is because of the TPO antibody, but there are certain studies which have shown that even thyroglobulin antibody presence is associated with fertility issues or problems. It affects about 5 to 20% of women in the childbearing age. It is more prevalent in infertile women, and it has been associated with increased miscarriage rate, may it be after spontaneous conception or ART. It decreases the oocyte fertilization and pregnancy rates in women undergoing ART. Then the presence of these antibodies, both TPO as well as thyroglobulin, are found to be in the follicular fluid. Now, women with endometriosis and PCOS also have found to have these thyroid autoantibodies, and also in women with premature ovarian failure. Now, what is the possible mechanism of AITD affecting? Now, it increases probably, it is associated with impaired cellular and humoral immune responses. It increases the natural killer cells. Now, it is suggested that the presence of these thyroid hormone antibodies and thyroid antibodies and increase in TSH both lead to increase in interleukin-2 production, leading into NK cell activation and leading to reproductive failures and miscarriages. There was this study which was published in 2007, and it showed that the relative risk of infertility was 2.1 times more in women who had presence of TPO and thyroglobulin antibodies as compared to controls. Another study, which was published in 2011, studied, it was a meta-analysis. Four studies were included in this meta-analysis, and they studied the effect of thyroid dysfunction and autoimmunity on fertility. Now they found that antibody positive women had subfertility more frequently than women without thyroid autoantibodies. Another meta-analysis, which included 19 cohort studies published in 2011, again concluded that the recurrent miscarriage rate was more in women who were positive for the antibodies as compared to who were negative, as well as subfertility was seen more commonly in women with thyroid autoantibodies as compared to ones who were negative. Now, in 2006, Negro, what he did was he supplemented these women with levothyroxine and studied the outcome for miscarriage and preterm birth. 115 pregnant women who were TPO antibody positive were randomized and were studied against controls who were negative. You can see here the miscarriage rate was high in TPO positive antibodies, which reduced after giving levothyroxine supplementation. Even the preterm birth was high in TPO antibodies, which reduced after the supplementation with levothyroxine. So the conclusion drawn was levothyroxine treatment in euthyroid TPO antibody positive women decreased miscarriage and preterm delivery. Therefore, it is prudent that screening for thyroid disorders in women with previous history of spontaneous abortions and treatment with levothyroxine is both cost saving as well as it improves the subsequent pregnancy rates. Now, you can see in this study, 4 different studies were done together, and all the 4 studies, 95, 99, 99, and 2003, all of them showed that miscarriage rate was more in women with thyroid antibody positivity as compared to ones with negative thyroid antibodies. It is therefore advisable to measure thyroid function and detect AITD in infertile women before ART and to follow up these parameters after controlled ovarian hyperstimulation and even during pregnancy. Even the American Thyroid Association guidelines say that euthyroid but TPO or thyroglobulin antibody positive pregnant women should have measurement of serum TSH concentration performed at time of pregnancy confirmation and then every 4 weeks through till pregnancy. It also goes on to say that levothyroxine may be considered in thyroid autoantibody positive women who are undergoing ART, given its potential benefits in comparison to its minimal risk. Let's come to subclinical hypothyroidism. Now, it's very clear that in case of overt hypothyroidism and TAI, it's prudent for us to supplement them with levothyroxine. What in cases of subclinical hypothyroidism and infertility? Let's define SCH first. It is defined whenever the TSH levels are more than 2.5 milli international units. This is as per the American Thyroid Society, but latest studies have shown that there is a gray zone between 2.5 and 4 milli international units. We'll come to it later. So various studies have quoted various prevalence of subclinical hypothyroidism and infertility. Now, this is probably because of the different cutoffs which we have taken. They have taken for TSH. Some of them have taken 2.5, 3.5, 4.5, 4, different. And that's why the prevalence is from 0.7% to 43%. But if we do the TRH stimulation test and we use that to detect subclinical hypothyroidism, then it is said that SCH prevalence is considerably higher. Okay, fine. Now, we just said that subclinical hypothyroidism, is there a relationship with infertility? So let's see what happens if we are supplementing these women of subclinical hypothyroidism with levothyroxine treatment. Now, this was a meta-analysis of RCT, systematic review and meta-analysis, which was published in 2013. 3 RCTs were studied or analyzed. All of them had more or less the same cutoffs of around 4 milli-international units to define subclinical hypothyroidism. Anything more than 4 was considered as subclinical hypothyroidism. And it said that the meta-analysis provides evidence that levothyroxine supplementation should be recommended to improve clinical pregnancy outcome in women with subclinical hypothyroidism and or thyroid autoimmunity undergoing ART. So supplement them with LT4, you will get better outcome. Again, another study published in 2011. What was the conclusion? LT4 treated group had significantly higher number of grade 1 and grade 2 embryos. Embryo implantation rate and live birth rate were also significantly higher, and significantly lower miscarriage rates in women or in group who was supplemented with levothyroxine. Therefore, again, supplementation of levothyroxine in women with subclinical hypothyroidism has a beneficial effect on the outcome. Another study published lately in 2018, it again showed that the miscarriage rate was reduced when levothyroxine supplementation was given, but preterm birth did not show any significant difference. However, in view of the reduced miscarriage rate, it's wise that LT4 supplementation should be given to infertile women with presence of thyroid autoantibodies undergoing IVF and ICSI. Again, 2017 American Thyroid Association guidelines say that LT4 may be considered in subclinical hypothyroid women who are attempting natural conception, given its potential benefits in comparison to its minimal risk. Now, when I say this, again, as I am saying, there is a gray zone between 2.5 and 4. Many of us follow the rule that if the woman is trying to conceive, the thyroid levels, TSH levels, should be maintained around 2.5 milli-international units. That's exactly what the 2017 guideline also say, that SCH women undergoing IVF or ICSI should be treated with LT4, and the goal of the treatment is to achieve a TSH concentration which is less than 2.5 milli-international units. This was an interesting study which was published in 2016. That's why I thought I should include this. Now, this was TSH levels in donors were studied, and then the outcomes of those recipients were studied. And they found that if the TSH levels of the donors at the time of oocyte retrieval was more than 2.5 milli-international units, then it negatively impacted the implantation and clinical pregnancy rates among the recipients. So it's not only the recipients whose TSH levels are important, but as we discussed earlier, that it has a faulty folliculogenesis, it also has an effect on the oocyte quality, embryo quality, and thus decreased implantation and clinical pregnancy rates in the recipients as well. That was about the female factor, but thyroid dysfunction also affects male partner. And what are those effects? They are more commonly seen in hyperthyroid patient males than in hypothyroid, but the presence of thyroid hormone receptors on the Sertoli cell itself says that thyroid also has to have a function to play when it comes to male fertility. So the issue or problem which is seen in hypothyroid males is that there is presence of teratozoospermia. The sperm morphology is altered, leading to decreased fertilization rates and decreased implantation and pregnancy rates. When it comes to sexual dysfunction, it is found that hypothyroid men have got hypoactive sexual desire, they have got delayed ejaculation, there is an erectile dysfunction as well, which gets corrected after the treatment, and that's what we want when it comes to an infertile couple. So in my last part, I'm going to discuss something about what are the recommendations given to us by different societies. We already discussed the American Thyroid Association recommendations in the presentations. Now, the latest 2021 European Thyroid Association guidelines on thyroid disorders prior and during assisted reproduction say that as a part of the subfertility workup of women, every woman who comes to us for fertility treatment should be worked up for thyroid disorders. How? By measuring TSH and TPO antibodies and thyroglobulin antibodies. Now, if the TSH levels are more than 4, initiate LT4 and control TSH before starting ovarian stimulation or before starting any treatment. Now, if treated, adapt LT4 dose 4 weeks before starting the ovarian stimulation. So if the TSH levels are more than 4 and we are starting with the treatment, wait for 4 weeks before we actually start with the ovarian stimulation for that woman. If it's in the range of 2.5 and 4, as I said, it's a gray zone, then go ahead and look for presence or absence of thyroid autoimmunity. Now, if there is presence of thyroid autoimmunity, check TSH again after ovarian stimulation. If the TSH levels are between 0.3 and 2.5, or maybe less than 0.3, then 0.3 to 2.5, then keep checking the TSH levels. And if they are increased, then only you should start with the treatment. And if the TSH levels are 0.3, we are suspecting hyperthyroidism. In that case, again, do an F3 and FT3 and FT4 levels, and then treat the woman accordingly. What are our own guidelines? What does the FOXI position statement say about thyroid dysfunction in pregnancy? These were published in 2019. It says that evaluation of serum TSH concentration is recommended for women seeking care for infertility. So all women who are seeking care for infertility should be evaluated by TSH concentration. Then LT4 treatment is recommended for all infertile women with overt hypothyroidism. LT4 may be considered in subclinical hypothyroidism, women who are attempting natural conception given its potential benefits in comparison to its minimal risk. In women with subclinical hypothyroidism who are undergoing IVF or ICSI, they should be treated with levothyroxine, and the goal of the treatment is to achieve TSH concentration of less than 2.5 MIU. LT4 may be considered in euthyroid women who are thyroid autoantibody positive and are undergoing assisted reproductive treatment given its potential benefit in comparison to its minimal risk. These are our own FOXI 2019 recommendations when it comes to thyroid dysfunction and pregnancy. Friends, to summarize, thyroid disease is a common condition in the reproductive endocrinology. Hyperthyroidism and hypothyroidism can have an adverse effect on reproductive health and adverse pregnancy outcomes. There is increasing evidence for the role of autoantibodies in subfertility and early pregnancy losses, even in euthyroid women. Evidence suggests that treating thyroid disorders and keeping the TSH levels at the lower end of normal in euthyroid women may improve conception rates in infertile women and reduce the early pregnancy loss. Thank you very much. Before I end, I would like to seek your blessings as I am standing for the chairperson's post of Endocrinology Committee FOXI. The election year is going to be next year, 2023. Please help me in going through this election process. At the same time, I would like to invite all of you for the National Conference on Reproductive Endocrinology, which we are going to hold on 29th, 30th, and 31st of July at Hotel Hyatt Regency, Pune. On 29th, we are going to have the pre-Congress workshops on intersex, managed diagnosis and management, and contraception, wherein we are going to have hands-on training in implants. And on 30th and 31st, we are going to have a full conference at Hyatt Regency. So save the dates and please do come down to Pune. Thank you very much for your patient hearing.
Thank you, sir.
Thank you, sir.
Thank you.
Thanks for the elaborate lecture. For our next lecture, which is on unexplained RPL and lymphocyte immunization therapy, I call on Dr. Priyakada Madam to introduce our next speaker, Dr. Mugdha Raut Ma'am.
Good morning, everyone. Immunology is the most difficult cause of RPL to deal with, and it stimulates our thinking out of the box when there are 7 to 8 pregnancy losses To solve these queries on RPL in relation to complicated immunotherapy role, I will welcome Dr. Mugdha Rao. She is MD DGO, consultant gynecologist and obstetrician. She has done her fellowship in clinical reproductive immunology. She is on education committee of American Society of Reproductive Immunology. She is writing a book on immunotherapy in repeated miscarriages and recurrent implantation failure, A New Horizon with Springer Publications. She is the partner at Dr. Raut's Center for Reproductive Immunology at Mumbai, Nagpur, and Kuwait. She is editor of EBWH Journal, Egypt. She was given Times of India Healthcare Achievers Award in 2018 for the innovative work in reproductive immunology. She has affiliations like member of American and European Society of Reproductive Immunology, AOGS, FOXY, and FIGO. She is awarded Femina and Cosmopolitan Top 10 Influential Woman, Primetime Healthcare Achiever Award, and Global Healthcare Achievers Award. Her publications are numerous in journals of American and European Societies of Reproductive Immunology. Her special interest is reproductive immunology, implantation failures, repeated miscarriages, and unexplained infertility. Welcome, Dr. Mugdha Raut, ma'am. Over to you, ma'am.
Thank you. Thank you, Dr. Priya, for the kind introduction. Shall I start my screen sharing?
Yes, ma'am.
Just a minute, huh? Just.
Yes, ma'am. Take your time.
Can you hear?
Yes, ma'am. Your screen is seen.
Yeah.
Just make it a slideshow.
Can you all see?
Yes. Yes, yes, ma'am. Yes.
Just a minute.
Yes.
Yeah, so sorry for the technical glitch. Today my topic is unexplained repeated pregnancy loss and lymphocyte immunization therapy. At the beginning, I would like to thank our teacher, Dr. Usha Krishna, who's considered to be the pioneer of immunotherapy in India, and my alma mater, Seth GS Medical College and KEM Hospital, from where I did my MBBS and MD, because of which institute I am here today. And I would also like to thank Dr. Mohan Raut, who's a partner of Dr. Raut's Center for Reproductive Immunology and a guest editor for the American Journal of Reproductive Immunology, without whose consistent support, our center would not be where it is today. Also, I would like to thank Dr. Priya Kadam, Dr. Manisha Shinde, Dr. Kiran Kuttakoti sir for organizing this and suggesting our name. I have very fond memories of Akluj when way back in 2014, just when our center had started, Akluj had invited us for a physical CME. We were invited by Dr. Vandana Gandhi. So let us see what is the definition of three or more miscarriages.
Hello. Ma'am, there is some network issue, I think so.
Kindly pause the recording.
Yes, yes.
Dr. Ashish Kayasar, Director of Asha IVF Center, Pune, Arunachal, Hyderabad, Dubai, Indonesia, Congo, Africa, almost all over the world. Director of Asha Kiran Hospital, Pune. Secretary-elect, Pune Obstetric and Gynec Society 2022-23. Clinical Secretary, ISAR 22-24. Executive Member, IAG 2018-2024. Executive Member,
Madam, shall I share the screen so that you can able to?
just a minute, sir, something went wrong. It's all visualize, sir, now.
No,
Screen is-
Manisha, no, your screen is not seen. PPT is not seen.
I will put the PPT, madam.
Okay.
Yes.
Sir.
Ashish,
Yes.
start sharing your screen, I think.
Yes, yes. I will do that. Everyone can see the screen.
Yes, yes.
Okay. Thank you,
complete, sir?
everyone. At the outset. Okay, you want to complete? Yeah.
Yeah. Executive Member IG 2018-2024. Executive Member of Maharashtra Chapter 2018-23. Founder, Librarian Maharashtra Chapter IG 2018-23. Treasurer Maharashtra Chapter ISAR 2016-2018. Vice President POGS 2018-19. Executive Vice President POGS 2016-17. He has won many awards: Champion of ESA 2022, Kaminirao Oration Foxy 2017, Foxy Future Award 2017, Young Achiever Award IMA 2017, Young Research Award POGS 2017. As a journal reviewer, member of Foxy Committee, Endometriosis Infertility IEC, has written many chapters, 30 chapters in textbook, 10 original research papers in index journal, and 500 and more deliberations in national and international conferences. Over to you, sir. Dr. Ashish Kaya, sir.
Thank you, madam. Thank you for those kind words. At the outset, I'm thankful to AOGS, as well as my dear friend and my mentor, Dr. Kiran Kurtukoti, Vice President of AMOX, and President of Akluj, Dr. Kadam, for inviting me here. Today, I'll be talking about something which the drugs comes into the market, stays in the market and goes with the wind. But again, there is a storm, then the wind comes again. So the ulipristol is the same, which has come into the market, stays in the market with the some complications coming in and gone out of the scenario. Again, it will come down because it has some role to play. Talking about ulipristol. All of us knows the abnormal uterine bleeding is not something new and not something that needs to be talked about, but the definition, 1/3 of the gynecological OPD visits is usually because of the DUB. The worldwide prevalence is 33 to 30%. In India, if you talk about the DUB patients coming down to your OPD is some around 17.9%. The causes may be a local or maybe a systemic. That's why we have a beautiful classification by the FIGO. So the definition per se, the AUB is defined as the parameter of the normal menstrual bleeding, established and defined as the symptoms that compromise AUB. It eliminates the term like menorrhagia, oligomenorrhea, and menorrhagia. Now, all of us doesn't cause the DUB, we call it as abnormal uterine bleeding. Uterine bleeding normal flow and what is the and what is the irregularity of the menses. When talking about the duration flow, if it is prolonged than 8 days, we call it as a prolonged menstrual bleeding. The volume may be in a blood loss when you call it as a heavy, normal, and the light, according to the patient terminology. The amenorrhea, no menses comes in the 90 days of the period, we call it as amenorrhea. The regularity of the period is the shortest to the longest. We know oligomenoric cycles, we know menorrhagic cycles. So we have to combine all these things when you're talking about the AUB. Then which comes into our system as when you're talking about AUB, the AUB should be has a systematic classification underlying like PALM-COHE classification. The PALM is which is having the polyp, that is a something which can be diagnosed when there is a symptoms of menorrhagia. We can diagnose it some pathology like a polyp, adenomyosis, leiomyoma, and those by any finding can be acquired distance causes iatrogenic and not yet been classified. Need what exactly the need of it? The need of it is having to say that one should take a detailed clinical history, physical examination, and laboratory supports for the investigations of AUB. So when you're talking about the AUB has some pathological causes which can causes identified and which later on detected by a laboratory investigations. Then we come down to what is the acute and chronic and intermittent AUB. Acute, when there heavy menstrual bleeding that requires immediate intervention, that is called as acute. The chronic, which the patient usually tell you the abnormal duration of the bleeding and it is coming in regular frequency, the in absence of the pregnancy, which can be termed and coined as a chronic AUB. Intermenstrual AUB is occurring clearly defined as a cyclical and predictable menses. May be in between the menstrual pattern, there is something like a abnormal bleeding. We'll not go into the details of it. The polyps and a leiomyoma will directly go to my talk of a leiomyoma in AUB. Well, all of us knows the leiomyoma contributes up to 70% of the prevalence. It has variable locations, size, numbers, and maybe asymptomatic or symptomatic. We need to about when we're talking about the leiomyoma, that is a universal classification and universal staging system. All of us know this FIGO classification. There is a submucous, intramural, and subserosal fibroids. Those which requires removal, those which requires surgery will be a different one. But those are asymptomatic fibroids. Definitely nothing treatment is required. But those are symptomatic fibroids required the treatment as a surgical treatment or as a medical line of a treatment. The uveomas and tumors has indications because many of the time when the patient comes to us with the heavy or abnormal menstrual pattern, we do the ultrasonography and we find it out. There are certain reasons where there is a fibroid, but these are the fibroids very much in a smaller in size, and these fibroids only been detected when the ultrasonography transform sonography has been done. This is a majority of the factors of a hysterectomy that all of us are knowing it. That these are the findings where all of us may suggest the patient of undergoing hysterectomy. But nowadays, the FOXI has a nice initiative, Save Uterus, and we are watching for the same. That if there is a smaller size of fibroid, less than 3 centimeters, and not that much symptomatic, one should not be going the hysterectomy, because we know it's not the only the procreation is the function of the uterus. There are many things which has been involved. In India, approximately 15 to 20 million of the women suffer from the fibroids. So if you're thinking of the problem ratio, the problem is much more than what we thought of. The predominant age which will have the positive prevalence of the fibroid was 45 years, is a 57%. So most of these females are going to have this particular fibroids issue in their reproductive age group. The fibroids common tumors, as I talked with, most solid pelvic tumors, and the recently reported indication for the major surgeries in premenopausal age group. The fibroids affects 35 to 77% in the reproductive age group and presents 5 to 10% of the infertile patients. And those who are having the infertility per se, if you are having fibroid, you are going to have a neat and clean surgery. No one knows whether there is going to have the adhesions formation or not, and that's why when you're talking about the surgical treatment of the leiomyoma, it should be talking with a pinch of salt. The incidence range from 30 to 70% in the perimenopausal age group. Why I'm talking about this? Because in certain situations, the patient is not fit for the surgery. In those patients, you require something to treat and reverse symptoms. Fibroids are the common of us are know that menstrual bleeding, one should be taking a detailed family history, menstrual history, rule out of the pregnancy. That is the one of the reasons, because these are the patients in the reproductive age group. They may have the pregnancy which is undiagnosed. So clinical history and clinical examination is much more and paramount importance. Determine the ovulatory status, screening for system disorders for him, evaluation of material care, and that will require a good TVS as well as a saline. MRI in certain cases definitely will be helpful for all of us to diagnose and treat this patient. So if the chronic AUB patient comes down to you with the 3 months and more with the excessive duration and the volume and the frequency, you need to investigate her. And investigations will require, first is a thorough clinical history, then physical examination, investigation, complete blood count, and then you need to go for coagulopathic disorders. If you do a physical examination and if you find it out there is something that really need to further evaluation, you can subject the patient for your. Now every gynecologist are equipped with the sonography machines. So what you will going to do is going to do the sonography and to find it out whether there is some structural abnormalities are there or not. If there is some structural abnormalities, definitely the uterine cavity is irregular. If the uterine cavity you found out is regular, then it is better to do a biopsy. All of us are doing a DMC or maybe a hysteroscopic targeted biopsies nowadays. All of us are doing, and that should be advocated. If you find out there is some abnormality in the uterine cavity, what is it, whether it is a polyp or whether it is a fibroid, then you need to come down to the basic diagnosis and the final diagnosis of the patient. Choosing the management is on the etiology of the AUB, depending upon the severity of the bleeding. If she's come down to the acute AUB, you need not to go for the management of the cause. It is better to stop the bleeding and improve the health, general health of the woman, rather than directly addressing to the problem. Associated is the symptoms. If the patient is symptomatic, maybe there is a pain, or maybe there is a symptomatic. When the patient comes for infertility and you diagnosed with the AUB with the fibroids, that needs required a different type of approach in that particular patient. It's a comorbidity. If the patient is in a perimenopausal age group and she has a comorbidity like hypertension and diabetes, in those patients, if they are not suitable for the anesthesia risk and there is a much more higher risk of anesthesia, one should be dealing with the medical line of treatment for this kind of AUB. The patient preference, you need to talk to the patient, you need to be a patient enough to listen to what the wants, rather than implying your line of treatment, rather than talking to her. You should, nowadays there is a called as evidence-based practice, wherein you give the different type of options to the patients, and the patients is wise enough, they will select what is suitable best for them. The treatment should not be initiated until the etiology of the AUB has been evaluated. And that's why, my friends, when you are talking about the AUB, one should be first categorically seen whether it is what investigations is pertaining to your physical and mind. Well, all of us don't venture directly into the sonography rooms and do the sonography for all the patients. It is better to evaluate the patient, evaluate the detailed clinical history and physical examination at most paramount importance in this particular field. So coming down to the uterine fibroids, what all we have expectant management, we have a medical and surgical management. Surgical management, definitely a submucous with the infertility requires management. Myomectomies, we have a different with this, have a Caesar, maybe a bipolar resectoscope. It is better to deal with those kind of myomas with the surgical skills. But if the patient is having a multiple myomas with the small myomas and the endometrial junctions, it is better to give a medical line of a treatment, because these are the medical line of treatment which shrinks the volume of the fibroids, which go away from the myoendometrial junctions, and those are the patients and this is very useful for them. If you are going to operate this multiple myomas and you are required to hold a Guinness World Record, it is for yourself and not for the benefit of the patient. So what are the things you can afford to? You can give a medical line of treatment, may have oral contraceptives, maybe a progestin intrauterine system, maybe a danazol. Danazol nowadays none of us are using because of the side effects, and you can give a GNRH analog. Again, GNRH analog and the OC and the progesterone system has its own effects as well as the side effects. Almost the oral increase size of the myoma in a longer run may have a breakthrough bleeding, increase the risk of venous thromboembolism, and that's why we are not giving oral contraceptive pills for a longer time. The intercurrent, the progestin, when you're giving, have a follicular cyst. All of us knows that whenever you down regulation IVF, you feel on a day 2, you do a scan, you find it out there is a follicular cyst, and this is because of the side effect of the progesterone. LAIUCD is the effect on the size of the myoma is still being debated. It is a high expression rate and the ovarian cyst and acne because of the progesterone effect. Coming down to GNRH analog, again, if there is some good things, well, but if you are really going to operate on those, don't use GNRH. This will cause complication of myomas and it will become difficult surgeries for myoma. As I told, I have never been using it, and we stop it down, and all of us should not be using the danazol as a treatment option for the fibroids. So what we have the selective progesterone receptor modulators, and these are the new class, because all of us believes in the past that the estrogen excess causes fibroids, and this is not whole true. Nowadays, there are these where the progesterone may be responsible for the enhancement of the fibroids, and in their management, we definitely have SPRMs, a new class of progesterone ligands displacing the tissue selective agonist as well as antagonist properties, and number of clinical trials has now been established, which will tell you that the progesterone blocking agents or maybe a selective progesterone receptor modulators are the treatment of choice in steroids. The ulipristal. We all of knows this ulipristal as a selective progesterone receptor modulator and used in the treatment of AUB where there is a leiomyoma. The clinical studies in Pearl 1, which also has the same results, effective control of AUB. It reduces the AUB as effective as that of the GnH agonist, as that of the lupride depot, but without the hypoestrogenic side effects. If you has been hypoestrogenic effects, and that's in adolescent age group where you're going to use this kind of a drugs where you are suspecting the anti-estrogenic or hypoestrogenic side effects. The ulipristal acetates nowadays, what we are using, and in the past also, is a 5 milligram, and and approved by the European Union for the preoperative treatment for the uterine fibroid. Today, ulipristal acetate is effective in conservative uterine fibroids. But then all of you will ask me why it has been banned by the DGCI and why it is again the ban has been removed. Definitely, it has been banned because of the certain side effects which has been observed when the ulipristal has been advocated for more than 3 months and 6 months. There are the reports wherein the liver dysfunction has been documented, and there are the one study which quoted by European nation that even if the liver transplant is required for the patient. But mind well, you must understand there are some effects as well as some side effect for the drugs. And if you are using it for a longer period of time, you will come to know what are the ways you can use that particular molecule in a betterment of the womanhood. The pharmacokinetics, I will not go into the details of the ulipristal. All of us are knowing it. It is a selective estrogen, selective progesterone receptor. It can be given orally and highly bound, that is 98% to the plasma proteins. It readily converts into the metabolites predominantly mediated by the CYP3A4, and this is the metabolism of the progesterone. Of elimination through the feces, and less than 10% is excreted through the urine. The pharmacokinetics, the treatment, how you can be started. Possible should be started within 5 days. Why this particular letrozole is started from day 2? Similarly, when you are talking about the ulipristal, the ulipristal has to be started within the first week of the menstruation, and you can give such a 4 courses of the ulipristal. Mind well, after the 1 course, you have to wait for the menstrual bleeding to occur. Then again, in the first week of the same menstruation, following the treatment course, you have to start. The intermittent treatment has studied up to 4 courses. What I mean 4 ulipristal course. Wait, again, you can give a second ulipristal course. I will go into the details how you evaluated it, how much and how long you can give a ulipristal. The in-home is definitely you can give the ulipristal in patients, where you can go for the ulipristal. My own research was there in 2013, and that is when published in Jogi Journal, where we are given the usual for multiple myometal junctions, and we found out that there is a shrinkage in the myomas, and that patient conceived. That was the case report which has been published there. We use ulipristal in perimenopausal women. Use in patients unfit for the or not fit for the surgeries. Definitely, you can give a medical line of treatment like contraindications. Definitely, there has to have some things that you may need to take into account. Who are severe disease, drug we are given those any reason. So you have to find out what is the cause of the bleeding, and then you can find it out whether I should be giving you acetate or not. Ulipristal acetate is not been intended to be used in the post-menopause woman, and with the patient is having asthma. It should. Then coming down to the why I'm talking banned now to the armament, because in 13 days 2021, this is the DGCI approval letter, which will clearly indicates in whom you can give and what one should be knowing before starting with. estimated exposure of the ulipistol for such a kind of a studies, they found out only 3 cases of liver transplant, which I was talking about. And that's why whenever you are going to use this kind of a drug, DGCI gives certain things in order to minimize the possible risk of to the patient. So contraindications where there is a underlying liver disorder. So whether you are going to start with the ulipristal, it is better to do a liver function test. If the liver function test, if you are doing in which is in the normal range, and there is the normal, it is better not to start it, or it is better to stop the treatment when your HOT, HGPT levels are 3 times higher than the normal range. One should not be you continuing in using the ulipristal acetate, and that is the point where you can stop it down. It means that this is the particular liver toxicity has been started, and you can prevent the complications. This is the way it should be started. Even the liver function state before starting the treatment, then you can give it for 3 months. After the 3 months of treatment, better do the liver test for the 4 weeks. At the end of the treatment, again you can start. So these are the 4 times you can give this kind of a drug. After the every treatment, you have to do LFTs of a gap of 2 to 4 weeks, and then again you can start with the ulipristal. This is the way what give this particular. What are in the India? Definitely, it can be used in a perimenopause age group where there is a surgery is contraindicated or patient is not fit for the surgeries. Those drugs must not be used for controlling the symptoms of the uterine while awaiting for the surgical treatment. So if you are formulated the patient where you are going for the surgical treatment, better not to give this particular drug is to be given for infertility patients where you are thinking of multiple fibroids, and those are myoendometrial junctions, those who are not fit for surgeries. Those are the patients in whom you start with this drug. Before starting the drugs, definitely you are going to do the liver function test, and after completion of one protocol or one treatment protocol, you have to do the LFTs, and the LFTs are 2 times higher the upper limit of the normal. It is better to discontinue treatment more than 3 times that there is a liver toxicity. One should not be utilized this kind of a drug in a lifetime. The restricted indications I already talked to you. So these are the things you can definitely thought of not using, and in certain cases definitely you are going to use the ulipristal. So it is in your hand as a doctor to prescribe certain molecules with a detailed knowledge and detailed history of. Thank you for patience hearing. I'm happy to take any questions.
Thank you, sir.
No, hello, Manisha.
Yeah,
हाँ,
ma'am is there?
Madam join. Yes.
Yes. We'll continue now Dr. Mugdha ma'am's lecture. Ma'am, you're there?
No, she is joining. Just a minute. She is joining. तोपर्यंत क्वेश्चन्स बघ मनीषा जर
Yes.
असतील तर.
I request the delegates to ask question to
The faculties.
whatever the lectures have been finished till now. You can ask questions on that. There is one question to Dr. Kanfule sir. If FT3 and FT4 are in the normal range, then
Yes, madam.
yes.
No, the question was, I answered that. The question was,
You
that
have
in
answered
cases
it.
of hyperthyroidism, what is the cutoff for T3 and T4? Now we need to look for free T3 and free T4. If they are above the range, we have to do it. It doesn't depend upon the TSH levels per se.
Oh. Most of the questions have been answered already.
Dr. Chaitanya, are
I
you
must say it is a wonderful seminar.
Sir.
are you still there?
Oh, aayegi.
Till the time Dr. Mugdha sets up a few discussion about TSH. Number one, when we do the TSH level, can you just tell me what is the difference between a TSH and what is ultra TSH? Because many times we are doing ultra TSH in Pune. So is there any difference, or which is the one recommended?
Ultra TSH is the one which is recommended. So it's the way to diagnose to do the TSH levels. So nowadays all of us do ultra TSH. There is no just TSH which we do.
Okay, fine. Now another question was that before doing TSH, do we need, if the patient is on thyroid tablets, does she take the tablet and then do the TSH, or she does the TSH first?
If she's already on medications, doesn't matter. Even if she has not taken that day's tablet, yesterday's the day before tablet is taken, that is good enough.
Okay, and is there any difference?
Because even when we say if she misses out on a tablet for a day or two, that's not going to change her TSH levels much.
Okay. Now another question is that in case we do a TSH from say X lab this time, and we do the TSH from say Y lab next time, would there be a difference?
There is a reference range which changes from lab to lab. So we need to look into that reference age and not at the absolute value. So if the reference range is different, because it depends upon the calibration from where the calibration has been done and all. It also depends upon the kind of if you are what you are using. Like there are various methods of doing analysis. So various ways. So depends upon that what is your reference range. So you have to always look for the reference range for that particular lab.
So when to repeat TSH after starting the treatment, and how to do the dose adjustments?
Every 4 weeks.
Okay.
You have to
Means
keep
after
repeating it every 4 weeks and then adjust the dose accordingly, not before that.
Okay.
And sir, if the values are normal in first trimester, we need to repeat in the third trimester?
Yes, because the throughout the trimesters, the need or requirement of thyroid hormone changes and it keeps increasing, and therefore we have to be sure that we are doing the thyroid levels throughout the pregnancy. Number one. Only the cutoff levels differ. They say that in the first trimester, the levels should be maintained around 2.5 as we discussed. But in second trimester and third trimester, we may be a little more lenient, and 4 is the value which they say that recommended as a cutoff.
Ashish, is there a comparative, Ashish, sir, is there a comparison between ulipristal and mifepristol?
Hey, Ashish, sir?
We are recording.
Oh, okay. As a record, sorry.
Ashish sir.
Yes, sir.
Yes, sir. Is there a difference between?
You call me Ashish, it is better. Yes.
Between
there is a comparison. There is a comparison between the mifepristone and ulipristal. Mifepristone, they are used is 25 milligram of a mifepristone and a ulipristal 5 milligram. So they found out that both the things are comparative as far as the large are concerned. If the myoma is a single myoma, they compare. If it is a larger myomas, the mifepristone is acting much more better way. If it is a multiple myomas, a smaller size, a ulipristal has a better effect.
Thank you. Great. Dr. Mugdha, are you ready?
Ashish sir, a question. Do you have any experience with the newer molecules which have come for fibroid treatment, like triptergium, some root extract and all? They are marketed by our company.
Fibronorm.
Yeah, there are the companies like what Dr. Priya is talking about is a Fibronorm. and the tryptozyme from the roots of that particular plant. I have not personally been used, and we have not done any of the research in that randomized studies where we are comparing these two. But myself has done a mifepristone and ulipristal, and that was published also, but not this tryptozyme that is been fibronum, which is there. I have not personally used it.
Thank you, sir.
I think Dr. Mugdha is
Thank you, sir.
Thank you, madam. Thank you.
Ma'am, you can share your screen.
Yeah. My host has disabled screen sharing.
Manisha. Hello, Manisha. Yes, yes, ma'am. You are now co-host.
Just a minute. I can't share my screen for some reason.
Ma'am, otherwise you can send your PPT. We will share from here.
Yeah. I mean, has anyone, there is no block, this, no, block,
No, no.
no, no.
Ma'am, you can share the PPT on the group.
Yeah, I will.
Yes. Manisha, you then start sharing PPT.
Yeah, I'll just send it on the group.
Yes.
Yes, ma'am. Yes.
I'll send it on mail or
Ma'am, on group, our WhatsApp group.
WhatsApp group.
Yeah.
Just a minute. Email. Back. Hello? Hello? Can I send it to Kiran, sir?
Yes, ma'am.
Yes, ma'am. Or you can send to the.
Send it to me. Send it to me. No problem.
Yeah, I just sent it.
Yes, ma'am. Yes, ma'am.
सरांना व्हॉट्सअप वर पाठवलंय.
Oh, it is there in the group. There are 87 slides. So as soon as it is downloaded, I will forward it.
Yeah, I'm sending on mail also.
Thank you.
Manisha, can you make me co-host?
Yes. Your co-host now.
Yes, I will try to share madam's.
I've sent it on mail also.
Ma'am, I'm sharing it.
Yeah.
Yeah, start it. Ma'am, you can start.
Yeah. Yeah. And once again, sorry for the technical glitch.
It's okay.
Yeah. So my topic is recurrent pregnancy loss, unexplained recurrent pregnancy loss and lymphocyte immunization therapy. I would like to express my gratitude to Dr. Usha Krishna, who's supposed to be the pioneer of immunotherapy in India and who introduced us to the topic of immunotherapy, and my alma mater, St. GS Medical College and KEM Hospital, Mumbai, from where I did my MBBS and MD, and of Dr. Mohan Raut, our partner in Dr. Raut's Center for Reproductive Immunology. He's also the guest editor of the American Journal of Reproductive Immunology. Next slide. I would like to thank Dr. Kiran Dr. Kiran sir, Dr. Manisha Shinde, Dr. Priya Kadam, and all the organizing committees of Akluj's Obstetric and Gynec Society for organizing this seminar and inviting me. We have fond memories of coming to Akluj in 2014. Sorry, the slides are going too fast. The slide before, yeah. In 2014, when we were invited by Dr. Vandana Gandhi for the Akluj CME, this was when our center had just started. Next slide. So, next slide. Next slide. So let us see what is the definition of repeated miscarriages. According to the American Society of Reproductive Immunology, reproductive medicine, 2 or more miscarriages are defined as recurrent miscarriages, and ISHRE defines it as 3 or more miscarriages. So according to the women affected by repeated miscarriage, okay, what do we do when there is just one first miscarriage when a couple comes to us? We say wait till the second one, then we will investigate. Next slide. And why do we say so? Because this is based on the following statistics. Risk of a miscarriage in any first pregnancy is 11 to 13%. After one loss, it is 14%. After 2 miscarriages, can you hear me? It triples.
Yes, ma'am. Yes, yes, ma'am.
After 3 miscarriages, it is 31 to 33%. And after 4 miscarriages, it is as high as 60%. And after 5 or more miscarriages, it goes to 77%. Next slide. Go by the Ministry of Statistics and Program Implementation team. Next slide. The number of couples with a wife in the childbearing age group is 170 per 1,000 population. And from that, we derive wife in the childbearing age group is 213 million. If we see the incidence of RPL as 2%, it is 4.25 millions. And if there is an incidence of 5%, it is 10.6 million couples. So if you see 50% of RPL, if you consider 50% of RPL which are unexplained, in India alone, we have 2 to 5 million couples with unexplained repeated pregnancy loss. Next slide. Now, the causes of repeated miscarriages have been explained by all the previous speakers. So today I will be only talking about these 50 to 60% of couples explained repeated miscarriages, and these couples. Next slide, please. Hello.
Hello. There is some network issue, I think so, ma'am.
Yeah. So when we look at immunotherapy in unexplained repeated miscarriages, we have to look at why immunological, what do we do for such patients, how immunomodulation works, and what are the controversies and recent evidences. Next slide. So why immunotherapy? We have to go back to the words of Sir Peter Medaber, who put up this question: how does a pregnant mother manage to nourish within herself for many weeks and months a fetus that is an antigenically foreign body? Next slide. Because we all know that our immune system is our body's protection against any invader, and with the help of cells, tissues, and organs, they work together to defend our body against attack by foreign invaders. Next slide. Yet this powerful defense system is overcome in mammals in pregnancy, where the fetus grows in the mother's body. Next slide. Now, this arrangement of viviparity does provide maximum protection against environmental hazards, but it introduces a critical requirement for circumventing or bypassing immune rejection. Next slide. Understanding how the maternal immune system responds to pregnancy is critical for our ability to better diagnose, understand, and treat various pregnancy complications. Next slide. Our immunological science has come to embrace an entirely unexpected aspect of the immune system, which may be called the yang of the Chinese balance, the yin and the yang, where yin is immunological destruction of invader antigens and yang is immunological tolerance to self, allogenic, and other antigens. The destructive forces of the immunological army are balanced by a second arm of the immune system, protecting the self as well as the fetus from unfettered responses. Next slide. This immunological equilibrium is extremely important, where lymphocyte activation is important for protection of our body against pathogens and foreign proteins, and for tolerance when there should be no response to self and other harmless antigens. Next slide. Now, as Dr. Kiran pointed out, that the fetus is a semi-allograft where the embryo and the gestational tissues express foreign antigens derived from the different maternal and paternal chromosomes. And as the fetus gets 50% of the MHC genes from a genetically non-identical father, the fetus is termed as a semi-allograft. This is known as the paradox of pregnancy. Next slide. So how does embryo protective immunomodulation happen? Whenever there is allorecognition, the decidua to respond to reaction producing the blocking antibodies, which then protect the pregnancy. On the other hand, the trophoblast produces HCG, progesterone,
Dr. Mugdha, you are muted. Dr. Mugdha, you are muted.
Yeah, the T regulatory cells have emerged as the central players in mediating this tolerance. Next slide. Now here I've again put the slide of TH1 cells, TH2 cells, TH17 cells, and T regulatory cells. What are required in pregnancy are the adaptive or the immune tolerance response to the embryo, the sperm, and the oocyte. Next slide. Whenever there's rejection response going to happen, there is failure of allorecognition, and the decidua and the peripheral blood attract the TH17 1 response. With the help of TNF alpha, interleukin 2, interferon gamma, there is a rejection reaction causing no blocking antibodies. On the other hand, the trophoblast cannot produce HCG, low progesterone levels are produced, there is low PIVF, there is no local immunosuppression, and there is a destruction of pregnancy. Next slide. So at what levels can an immunological attack happen? Immunological attacks can happen at the ovulation when there is a recovery of the eggs. It can happen before implantation, and it can happen even after implantation because of the TNF alpha damage. Next slide. So what do we do for such patients? First, we have to investigate for the alloimmune factor and then do the immunomodulation. Next slide. So let's divide the investigations into all the available investigations which we do, and what are the newer aspects. Next slide. All the available investigations worldwide are lymphocyte cross-match, peripheral NK cells, complete assay, and an NK cell inhibition panel, uterine NK cells, serum TNF alpha, HLA DQ alpha genotype, T regulatory cell estimation, TH1, TH2 intracellular cytokine ratio. Next slide. Next slide. The previous slide, please. Previous slide. Okay, so the investigation which we do are HLA cross-match, the peripheral NK cells, endometrial NK cells, and the serum TNF alpha. Now, what are the newer updates are endometrial immune profiling and immune checkpoints. Next slide. The endometrial immune profiling was designed by Nathalie Lady in France. And next slide, please. And she has categorized the endometrium into 4 different categories, and where they propose that there would be individualized treatment based on the endometrial immune profiling. The next slide. The immune checkpoints are very commonly used in cancer immunotherapy, but I'm sure they're going to come up in reproductive immunology with its because PD-L1 is seen on the trophoblast and PD-1 is seen on the immune cells, which are responsible for immune suppression. HLA-G G expression on the trophoblast, CTLA-4 on the maternal immune Treg cells, T-cell-IgG mucin 3, lymphocyte activation gene, T cell and B cell lymphocyte attenuators. Next slide. So then once we diagnose a patient who requires immunomodulation, what do we do? Next slide. Immunomodulation can be of two types: active, that is stimulation with an antigen, which involves lymphocyte immunization therapy, and passive immunomodulation. Next slide. Now, any kind of LIT which we are going to do, we are going to see in they're going to help in the formation of the inducible T regulatory cells. Next slide, please. So the various modalities of immunomodulation our previous speakers have already spoken, but I will be only speaking about lymphocyte immunization therapy. Next slide. Now, lymphocyte immunization therapy, it is done any time of the cycle, even in pregnancy. It is a daycare procedure. Blood is collected from the husband or a suitable donor. Lymphocytes are separated and the lymphocytes are injected intradermally in the wife. Next slide. Prior immunological testing is very important. Infection profile is a must. Blood group of both the partners is a must. If LIT is done before pregnancy, the couple is asked to plan pregnancy 4 to 6 weeks after therapy. The effect of this therapy lasts for 18 months. A booster dose may be given in the first trimester, but we have never given one. And LIT can also be given in pregnancy if the patient presents with pregnancy. Next slide. Now, LIT has been studied with 4 main areas of efficacy, mode of action, patient selection, and side effects. Next slide. Now, considering efficacy, next slide. The efficacy of LIT has been studied way back from rather 1985. In 1994, Daya and Ganvi, Dr. Manoj Pandey later on in 1994, the recurrent miscarriage immunotherapy trialist group. Next slide. Professor Mowbray, Professor Howard Karp, Bayros, Lee Wu have all shown the beneficial effects of LIT. In 2019, there was a study which was conducted by Sarno. Next slide. Where he studied, it included couples with repeated miscarriages with lymphocyte crossmatch that were negative, and he divided into 4 categories. One with only alloimmune problem. The second category was alloimmune and thrombophilia. The third category was alloimmune and autoimmune. And the fourth category was alloimmune, thrombophilia, and autoimmune. Now, each category was divided into 2 groups. One was given LIT and the other was not given LIT. And in all the groups, the associated conditions were treated. Next slide. When the outcome was compared in the group, the LIT group, which was the number was 752, they found a 60.1% success rate. And where LIT was not given, the success rate was only 33.1%. Next slide. So this is again the same study. Next slide. Now, what is the mode of action of LIT? LIT will act by activation of lymphocytes, proliferation of lymphocytes, and differentiation of lymphocytes. The dendritic cells, previous slide, please. Okay. So the dendritic, okay, I'll just explain to you the dendritic cells along with the which are present in the skin, along with the allogenic lymphocytes, they're taken to the secondary lymphoid organ, that is the spleen and the lymph node, where there is an activation and proliferation of the lymphocytes, and the lymphocytes are differentiated into the T regulatory cells and the antibody producing B cells. Next slide. How are the patients selected? The patients are selected with the immunological test. Profile is a must of both the partners. Next slide. Now, if you have to see the side effects, there can be minor local allergic side effects, occasionally mild malaise, no serious allergic reactions like anaphylaxis, and no graft versus host disease. In the largest study, by Kling et al. In 2005 of 4,500 cases, there was no anaphylaxis, autoimmune disease, or graft versus host disease reported. Next slide. So if immunotherapy is so good, then why is it not so popular? So what are the controversies and the recent evidences? Next slide. Now, the use of LIT had become very widespread and was an accepted treatment until 1999, at which time the results of a large placebo-controlled trial called the REMIS study showed that LIT did not increase the chances of live birth compared with placebo, but rather tended to decrease it. This was in 1999. Next slide. So in the REMIS study, it showed that immunization with paternal mononuclear cells did not improve the pregnancy outcome in women with recurrent miscarriage. And despite a history of unexplained recurrent miscarriages, nearly 60% control patients who became pregnant had successful pregnancies. Because of the lack of benefit recommended against LIT as a treatment for unexplained LIT, this study recommended against LIT as a treatment for unexplained repeated miscarriages, and the higher rate of miscarriage and a greater gestational age was seen at the time of miscarriage was seen in the immunized group. Next slide. Next slide, please. So what were the criticisms of the REMIS study? It was the only study till date which observed a negative effect of LIT. The lymphocytes which were prepared were stored for several hours at temperatures between 1 and 6 degrees centigrade, which was shown by David Clark. I'll show you subsequently. They had discontinued the study before they reached the initial number of participants. It did not exclude patients with autoimmune disorder, that there was lack of post-immunization control of immunomodulation, and the lymphocyte concentration was never fixed. Next. Professor David Clark showed that the cell surface CD200 cell surface CD200 antigens are predictors of the success of lymphocyte immunization therapy, and they can be destroyed when the lymphocytes are stored for a longer time, more than 6 hours. Next study. So the subsequent Cochrane reviews were all based on the REMIS study, which showed, that's why they said that paternal cell immunization, third-party donor leukocytes, trophoblast membranes, and intravenous immunoglobulins provided no significant beneficial effect over placebo in improving the live birth rate. Next slide. Now, the Cochrane meta-analysis with the Ober study showed an odds ratio of 1.22. Next slide. The flaws in the Cochrane review were that they did not tell whether they were primary or secondary aborters, the number of miscarriages, the immunizing dose was not told, route of administration was not fixed, and it was not fixed whether it was the partner or the donor cells. Next slide. Now, another study was done without the Ober study, which showed an odds ratio of 1.63. Next slide. So in 2016, when Liu et al. Submitted this paper in the American Journal of Reproductive Immunology, where they showed a 77.5%, 77.8% success rate when the Ober study was removed from the Cochrane meta-analysis. Next slide. And when they had completely removed it, they showed an odds ratio of 4.02. Next slide. Now, Cavalcante in 2017 did a meta-analysis, and he included the Ober study and another study by Stray Pedersen, which was never published. Still, he found a significant improvement in the live births in couples treated with LIT. Was hello.
Ma'am, you are audible.
Hello, can you hear me?
Yes, ma'am.
That time the odds ratio was 3.13. Next slide. So the conclusions from the Liu and the Cavalcante meta-analysis showed that the LIT is a safe treatment. It stated that LIT is valid treatment for couples with repeated miscarriages when performed with lymphocytes from fresh, non-stored blood. It is beneficial when given before and during pregnancy. The best results are seen when LIT is done with adequate number of lymphocytes when applied intradermally and in well-selected couples. Next slide. So this was the study efficacy which was again showed by Sarno in 2019. Next slide. Next slide. This I've already mentioned it before, so I'm showing one. Next slide, please. Yeah, next slide. So Sarno had concluded that careful laboratory tests may identify subgroups of repeated miscarriage patients most likely to be benefited by LIT, and LIT even during pregnancy may significantly improve the success rate. Next slide. So what are our studies? Next slide. American Society of Reproductive Immunology in American Journal, where 90 was studied for the immunological factors. 75 couples were given lymphocyte immunization therapy, and there were 57 pregnancies so far at that time. So we had shown an 82% success rate of all the patients, because 42% delivered full-term babies. 9 pregnancies were ongoing at the time of the submission of the paper. There were 6 miscarriages, and all these patients with 6 miscarriages had raised TNF alpha. Next slide. So who will benefit? Next slide. All the couples with repeated spontaneous miscarriages should undergo immunological investigations to rule. Success depends on the proper selection of couples with immunological investigations for immunomodulation and treatment modulation. Endometrial immune profiling may be a newer aspect to personalize immunomodulation, and there could be newer role of immune checkpoints in pregnancy. Next slide. All these factors are going to be published in our book, which is going to come in the first week of August, called Lymphocyte Immunization Therapy in Reproductive Failures by Springer Publications from Germany. Next slide. Especially Professor Joanne Quack Kim, Dr. Ole Christensen, and of course, all our patients, referring doctors who believed in lymphocyte immunization therapy. These are the photographs of only some of the beneficiaries. We could not put in 1,500 photos, so we have just put up a few beneficiaries' photos. And in the words of Professor George Nduque, when we are asked what is the proof of LIT, and he says the proof of LIT is the babies. And I'm sure you all will accept this. Next slide. I would like to end the talk with the words of Sir Peter Medawar. The purpose of science is to change belief. And if you believe that infertility, implantation failures, and recurrent miscarriages are God's will, which is you will never try to find an effective treatment. Next slide. Thank you. Thank you for all the help rendered by your society for this talk.
Thank you, ma'am.
Thank you, ma'am. Any questions to Mugdha, ma'am? From any delegates or from our esteemed speakers? Okay, now we go further. I call on Dr. Ganesh Vagmode, sir, Vice President, Akluj Obstetric and Gynec Society, for vote of thanks.
I'm audible, madam?
Yes, sir.
Yes, sir.
It's our duty as a Vice President of Akluj Society to thank all the esteemed speakers who are speaking since morning on a very important topic of recurrent pregnancy loss. I would initially thank Dr. Nilesh Balkodi sir on his talk on role of heparin in RPL. Secondly, I thank Dr. Kiran Kurti sir for his excellent lecture on role of immunoglobulins in RPL. Thirdly, I would like to thank Dr. Chaitanya Ganpuri sir, who was my lecturer when I was in BJMC, for his excellent talk on role of hypothyroidism and fertility. Next, I would like to thank Mugdha madam on his excellent lecture on unexplained RPL and LIT. And lastly, I would like to thank Dr. Ashish Kare sir for his excellent lecture on use of Uripistil in AOB. I would like to thank my president, Dr. Priya Kadam madam, Dr. Manisha Shinde madam, for arranging such an excellent webinar on behalf of Akluj OBGYN Society. So thank you for this excellent management and excellent talk by all the speakers. Thank you, ma'am.
Thanks to all the
Thank you,
speakers.
Dr. Ganesh.
Thank you.
Happy to see you after a long time.
Yes, sir. You are my lecturer in Sir BJMC.
Yeah, I remember.
Yes, sir. Thank you, sir. Thank you very much.
Thank you.
Thank you all the speakers for their time.
Okay, thank you.
Thank you, Priya madam.
Thank you. Thank you, sir. Thank
Thank
you
you,
all of
Manisha
you
madam.
for sparing your
Thank you,
Sundays.
sir.
Thank you.
Thank you, Kiran sir.
Thank you, Dr. Kiran
Thank
sir.
everyone.
Thank you, Kiran sir.
Have a nice
Thank you.
weekend. Yeah. Bye.
Yeah. Thank you.